All right, it's 12:05, so I think we'll get started. Hi, everybody. Thank you so much for joining. This is Flash Talk Track 7, focused on real-time monitoring and digital phenotyping. And we have a great lineup of 5 speakers who are going to be talking about their research. My name is Noah. I'm a clinical psychology grad student at the University of Virginia. I'm just here to introduce the speakers and make sure that things run smoothly. So each Flash Talk will be about 5 minutes. After each talk, we'll have a few minutes for questions, so folks can unmute to ask those questions, or they could write them in the chat if they feel more comfortable doing that. And if we happen to have time at the very end, then we'll open it up to questions for the panel of speakers broadly. So first up, we have Jodie Nghiem from Weill Cornell Medicine. So Jodie, you can go ahead and share your screen and get started on your talk.
Sounds great, thanks. Is my screen sharing correctly?
Yes, we're all good.
Great. Hi, everyone. My name is Jodie Nghiem, and today I will be sharing a qualitative study by a collaboration of researchers at Cornell Tech, University of Pennsylvania, as well as UnitedHealth Group. And the study is entitled Understanding Mental Health Clinicians' Views on Using Passive Patient-Generated Health Data for Clinical Decision-Making. Before beginning, I'd like to acknowledge that this work was partially funded by the NSF as well as the Digital Life Initiative at Cornell Tech, and I do not have any conflicts personally. So patient-generated health data is defined as health data, health-related data created, recorded, or gathered by patients. And this type of data has great potential to augment the delivery of mental health care. This data can be collected by a variety of tools such as smartphones, surveys, wearables, sensors, and social media. And recently, digital health tracking has been rapidly increasing in popularity. So in 2015, just under 20% of individuals used at least one of these tools that can collect this kind of data, whereas in 2020, this increased to over 50%. So furthermore, this type of data can be categorized as active or passive, depending on the amount of user participation involved. So we have passive data, which does not require any user participation and is captured by digital mediums. Examples include step counts, sleep duration, mobility, whereas active data does require participation by the user and can be collected via analog or digital mediums. And a classic example includes self-reported health outcomes, such as the PHQ-9 or GAD-7. So our study seeks to understand how this type of data fits into clinical decision-making. And to do so, we conducted semi-structured interviews with 12 mental health clinicians offering outpatient services in New York City. 11 participants were psychiatrists, 1 was a psychologist. This represented a diverse array of experiences from under 10 to over 30 years of clinical experience. And half of participants worked in private practice, while the other half worked at an academic medical center. So for our findings, our first finding is that the current use of passive patient-generated health data is very patient-driven. So participants' experience with this type of data was limited to times that patients themselves were collecting and bringing this data to their appointments, such as Apple Watch data. And participants also expressed skepticism and hesitancy when it came to the accuracy of these measures compared to current gold standards. So moving forward, we recommend that researchers can continue to build an evidence base that shows the specific use cases for passive data that can address specific clinical challenges in order to increase adoption by providers in addition to patients. Second, we saw that our participants viewed the shift from active to passive data collection as a shift from prioritizing subjective data on mental health to more objective data regarding behavior. And while our participants weren't very concerned of which one is more valid than the other because they thought this data could be complementary to each other, they did fear that this reduced the amount of opportunity that patients had to reflect upon their mental state and mental health during their treatment. So moving forward, passive tracking technologies can be adopted to provide more of an outside opinion on symptoms in addition to active data collection that's traditionally used, such as the clinical interview. And the amount of how much this is used can be treatment dependent. So for example, therapy versus medication treatment. Third, we found that passive patient-generated health data must be delivered at appropriate times for action. Physician burnout is already a major concern, and our participants express further concern that this need to review this constant real-time passive data outside of clinical encounters can overburden already burned out physicians and providers. So in order to mitigate this, our participants recommended either dosing this passive data as a prescription or ordering it as a lab test to allow discrete data collection. So by borrowing from current practices in mental health care, this data can only be collected when both the physician or the provider and the clinician, and the patient have the bandwidth to actually use this data in a useful way. And then finally, participants expressed hesitancy and concern about collecting this very personal type of data from their patients, such as sleep and activity. And to mitigate this risk, they suggested proactive approaches to privacy in order to both mitigate these risks, but also create opportunities for engagement. So for one example, they recommended a very hands-on guided consent process in order to increase patient engagement, as well as integrating this consent process with goal setting so that patient goals for treatment are very highly aligned with the actual process of data collection of this passive data. So that is all, and thank you so much.
Great, thank you so much. So now we can open it up for a few minutes of questions.
Any sense of how people thought they might integrate this into the workflow if they thought it was helpful?
Yeah, so in terms of integration, one of the major things we heard was EHR integration, but that is kind of twofold. They didn't want it, like as the third finding said, to be continuously available because that requires a lot of liability. There's a lot of provider burden to that, but there needed to be enough integration so that it was seamlessly kind of integrated into the workflow. So there was kind of a tension there that we revealed with our participants.
Did you talk with them about care managers at all?
Sorry, about care managers?
Yeah, like a filter between them and.
Yeah, so a couple of our participants did kind of throw around the idea of maybe a person to filter this in real time. I think one of them suggested like a nurse practitioner or like a physician assistant, but I think that was only one or two that talked about that as a possibility.
And Samir, you could go ahead.
Great talk. Thank you for that. I was wondering if there was any broad themes in types of passive data that clinicians thought was more or less useful or reliable, or any that they'd take potential action based on.
Yeah, so that's a great question. So kind of the main types of passive data that came up, we opened the discussions really broadly and we didn't really bring up any specific examples. The ones that came to their mind were activity, step count, and sleep, a lot of the stuff that smartphone like Apple Health and Watch collects. In general, they don't have a proactive approach to integrating this into clinical decision-making and making like decisions based off of it. A lot of what we heard was the patients will bring this into the kind of the appointment, and it'll be used as like a goal setting, kind of like tracking accountability measure. And there was no like systematic way in which they were approaching integrating this kind of data into actual like treatment decisions and things like that. It was very kind of exploratory or first steps.
And we probably have time for one more question. So there's a question in the chat. Was there any discussion on a clinical decision support tool to inform potential recommendations to tailor treatment plans?
Yeah, I think that's a great suggestion. Yeah, I don't think that came up, but I think definitely a thing to explore in the future. Thank you for calling that out.
Thank you.
Great. Yeah, thank you so much, Jodie. That was such a great talk. Next up, we have Alberto Martínez from Maastricht University. You could go ahead and start your presentation.
Sure, thank you. I will just share my screen. Can you see it properly?
Yes.
Yeah, okay. So yeah, I'm Alberto from Maastricht University in the Netherlands. I'm working for a project called New Science of Mental Disorders, and today I'm not going to present anything too specific, just the vision of one of the projects of the consortium. So I'm going to talk about a possibility that we are working in, and hopefully I can make you think about it a bit, which is the possibility of using mobile phone technology and ecological momentary assessment and digital phenotyping to tailor treatment selection to people with mental health problems. I want to start the presentation asking where are we going in the field of psychopathology and clinical psychology. And of course, we are going to many places, but one of them is very clear, which is individualization and personalization. I did a quick search of the mission statement of a bunch of companies, and I found this. It all gets very personal. It's all about personalized care. Cannot see this one. Personalized, personal support, personalized health programs, personal advice, etc., etc. It's all about personalization. Then we have more original marketing themes that talk about tailored instead of personalized, adapted to user feedback, etc., etc. In academia, is not different. In this histogram, you can see the number of articles dealing with personalized related topics in the field of psychopathology and how it's been increasing steadily in the last years. So it's clear now, I'm not discovering anything new when I say that we want to work on personalization, but how do we get there? That's the question. And we've actually been doing that for long. We've been doing that using diagnosis. We've selected treatment to people based on their diagnosis, right? So a person comes, a person receives a diagnosis, and then you select the treatment for that person based on that. But the problem with diagnosis is that they are extremely heterogeneous. I like this article a lot because it shows what these people did was counting the number of profiles you can get with any possible combination of major depressive disorder criteria. And they found more than 10,000 different profiles, only for major depressive disorder. And these are 10,000 different problems. And if you give the same solution for all these problems, it's no surprise that treatments don't work so well, right? And I'm not discovering anything new. A lot of people have already realized that, and they have tried to allocate people to different treatments based on different information. There's people who has worked with biomarkers, with social factors, with contextual factors, etc., etc. And what I want to talk about is about about the different possibility, which is allocating people to treatments based on how their problems affect each other in their daily lives. And for that, we use ecological momentary assessment and digital phenotyping. We ask people for a number of days, several times per day, about their thoughts, emotions, behaviors, context, and we also gather passive data. For example, imagine that in a day, we ask a person 8 times, like I have in this graph, and this person answers 6 times. By doing this number of days, we can get a timeline of what happens to this person, and then we can see what happens after a symptom onset. Does this symptom provoke other symptoms? Or we can see what happens after an event. What happens after this person doesn't sleep properly? Does that trigger other type of problems? And we believe that this is very useful information for treatment allocation. And what we do with it is we create networks. Imagine we have a network with 5 variables: sleep, anxiety, mood, suicidal ideation, and social interactions. With this information, we can see, for example, in this case, how a person who sleeps.
It was very expensive, and you had to. It was like bad packages.
Sorry, we can see how a person who doesn't sleep properly gets a worse mood, and that also increases suicidal ideation and decreases social interactions, which also worsens mood even more. But for another person, perhaps it all starts with anxiety, with an anxiety problem, which worsens sleep and mood. Sleep also can worsen mood even more, and that makes the person suicidal. A third case could be like a person who has problems with social interactions because they increase their anxiety, and that affects sleep and mood. But the question is that even though we see this type of problems, we don't know what treatment works best, right? Perhaps in the first case, even though suicidal ideation sounds very serious, we should intervene on sleep because that's where the cascade of effect starts, right? The second person also has a sleep problem, but it's provoked by anxiety. So maybe we should focus on that. So what we try to do in my project is we try to find different phenotypes of networks, and then we want to see what treatments work best for this type of networks. So as a conclusion, it seems like a combination of mobile phone technology with ecological voluntary assessment and passive data can be useful to build networks, and that can be informative to tailor treatment selection. We will see if it works or not. I don't see this happening in industry. I don't know if it's because people don't believe in it in that field. And I would be very happy to chat about it. You have my contact information there. And I want to also just mention my supervisory team and thank them. And I will be taking questions. Should I stop sharing the screen or?
Yeah, I think that would be a good time to stop sharing your screen. So yeah, we have a few minutes of questions, so feel free to unmute or pose a question in the chat. Really great talk. Thank you so much.
Thank you.
I can kick it off. So I know we're a little bit of a ways away from clinicians actually being able to kind of use this kind of EMA data and being able to kind of see these like types of networks and make decisions based off of that. We're still like very much, my understanding, in the kind of like, research stage of things. But once we get there, what do you see as like how would clinicians be able to kind of digest all of this information? Would it be some kind of dashboard that you see them using? Yeah, I'm just curious your thoughts about that.
Yeah, it's an interesting question, and there's some people already trying to think about it, right? Because clinicians may not have the technical knowledge about how to build all these networks. Behind these networks, there's a lot of statistical complex modeling. So the way I see it is that perhaps that should be in charge of other people, right? And I think that since we are moving to a data science focused world, it wouldn't be that outrageous to think that data scientists could help clinicians and collaborate with clinicians in order to build these networks or to work with this type of information, so that then clinicians just get information and they use them as they seem more fit, right? That's how I see it a bit.
Thank you. And Abhishek, you can go ahead.
Yeah, thank you for this very interesting talk. I have not seen much of network analysis with the EMA data sets. So I was just curious to know how do you think about the validity of this analytical approach compared to the other models that we have been running, and how do you test the accuracy of the model that you run and therefore its implications on the real world?
So the thing is that you can build networks in many different ways, right? You have EMA data, and you can just use a multi-level model to build the networks, but you can also use a time series model. And that also means that you need different validation process. And to be honest with you, nobody knows this at the moment. Like there's, for example, a university in Belgium that is called KU Leuven that is working a lot on ways to validate networks built from multi-level models. But it's just an ongoing work because the whole field is quite new, and people don't know so well how to do it because, yeah, we haven't worked with it so much. So I don't have an answer for you. I'm sorry for that. But yeah.
No worries. Thank you.
Thank you.
We probably have time for one more question. So in the chat, we have a question. Could you say more about how it's going with the treatment matching to different phenotypes / networks?
Yeah, I think there's no problem if I talk about it. The consortium is starting, they should start anytime soon, a big study where they are going to recruit patients from different clinics And then they will gather this type of data and they will build the networks. And then they will see how people with different networks react to different treatments. It should happen anytime in the next years, but the consortium is funded for 10 years. So it's more of a medium term goal. It won't happen anytime very, very soon. Thank you.
Great, thank you so much. So next up, we have Dr. Caitlin Stamatis from the Center for Behavioral Intervention Technologies at Northwestern University Feinberg School of Medicine. So you could go ahead and share your screen. Also, apologies in advance if I mispronounce anybody's name.
Pronounce it perfectly, and thank you, Noah. Okay, am I sharing the right thing?
Yes.
Awesome. Okay. Cool. So hi, everyone. Thanks so much for being here. I'm super excited to get to share some of our research done with Jonah, who I see is on the call. Hey, Jonah, on passive sensing of social anxiety. So quick context, at least in small, primarily student samples, what we're seeing so far is that a combination of call, text, accelerometer, location data relate to social anxiety. But the fairly large effect sizes reported in early studies have not really replicated in larger samples, and there's also just a lot we don't know. So one thing is around timing, right? So the lag time between when a sensor is collected and when we measure symptoms varies a ton across studies. So even in the features where we have stronger evidence, we don't know, are these leading indicators, lagging indicators, and if they are leading indicators, how far ahead of clinical symptoms do we see them? And then relatedly, if we want to eventually leverage changes in sense data to trigger personalized interventions, we really need to better understand these within-person changes in sense data, how they relate to within-person changes in symptoms. And then with social anxiety, and honestly with most psychiatric conditions, an added challenge is symptom heterogeneity. So for example, with social anxiety, we have fear of social situations, avoidance, physiological symptoms. These all would likely have distinct kind of sensed indicators. And avoidance especially is of interest to us, right? It's a central maintaining factor. Changes in avoidance predict other changes during CBT, and treatments that target avoidance early tend to have better outcomes. So what sensed features specifically relate to this maintenance factor? That's sort of what we were trying to identify in this project, addressing these challenges and looking at a suite of sensed smartphone features as they relate to future avoidance, fear, and physiological symptoms in social anxiety. So these data I'm talking about come from the LifeSense study led by David Moore. This is a 16-week sensing study in over 1,000 people. We had other components like EMA, text message sentiment, but today I'm just focusing on our passively sensed phone data. And this is a conceptual model we were testing. So we have the 16 weeks of sensor data on the bottom. Symptoms were collected every 3 weeks. On the top, so saying, okay, if we take a 2-week window of sensor data, how well can we predict your levels of social avoidance, fear of social situations, physiological symptoms 2 weeks later? And then we said, what happens if we shift the prediction window forward 1 week? And what happens if we shift it forward again and look at effectively contemporaneous relationships? And we were focused analytically on getting at these person-specific effects in a sample of just over 1,000 people. So a lot going on here, sorry, but I'll try to focus on key takeaways. So here we're predicting avoidance. The first column has all of the sensed features we looked at. B is a between-person effect, W a within-person effect. The second column is the prediction, basically 2 weeks in the future, 2 weeks out. Third column is 1 week out. And the last column is contemporaneous. And so you can see highlighted in yellow here and boxed in, the most consistent predictors of avoidance were call and text-based communication decreases. And then also what we're interpreting as kind of reduced novelty seeking, going less to these unfamiliar places. And I'll note that with calling and texting, right, some of these are person-specific effects, right? So we're not just saying that people who call and text less are more socially anxious. We're saying that when people start calling and texting less, they're more likely to report future social anxiety symptoms. And then super quickly, with fear, we saw pretty similar results to avoidance in terms of communication, but also increased in-person time spent at home. And then physiological distress, as we might expect, look quite different, associated with in-person increases in gaming app use, which is interesting. So just quickly to wrap it up, what I think is interesting about these findings is that, again, we see this dissociation of sensors predicting physiological distress versus fear and avoidance here, super aligned with treatment research, right? These two symptom domains move together in treatment, and they tend to move independently of physiological distress. And then from a treatment implications perspective, we're seeing how important the context and timing of sensing is, right? So if I were to try to personalize a treatment based on these findings, which I do not recommend anyone do, I would maybe want to deploy some type of prophylactic content when a patient starts calling or texting less for avoidance versus when they're spending more time at home for fear of social situations. And then the other thing I consider is that the features that exclusively related to symptoms at the between person level, like novelty seeking, would probably not be very helpful signals if I want to understand who is going to deteriorate and when. And then the last thing, super quick, is that, and very important, I think, we're not explaining a lot of the variance here, just over 10% in social anxiety outcomes, a lot smaller than earlier studies and smaller and more homogeneous samples, but interestingly higher than what we see when we try to predict GAD and depression in our own data. So sorry I'm over time. Here's my contact info. Want to acknowledge our amazing collaborators and our funding sources, and thank you all for listening.
Great, thank you so much. Yeah, we'll still have a few minutes for questions, so feel free to Zoom raise your hand or, yep, Abhishek, you go ahead.
Yeah, thank you so much for this study. So I'm pretty interested in the EMA data and especially the within-person associations. So I noticed that the significant effects were more between person than within person in your results. So I was curious to know whether your interpretation of the results is more about general population, like more at the between person level, rather than saying that higher levels of something within a day or within weeks leads to higher levels of something else, maybe like the social anxiety disorder. So just trying to understand the results interpretation again from you.
Yeah, thanks for that's such an important question. And again, I think our interest is thinking about how can this type of study sort of lay the groundwork for future attempts to personalize interventions based on these signals. So of course, what really interests us is the within person change. And so I kind of glossed over our between person effects because yes, they're interesting, but they're also sort of what we already know, right? We know that these correlations are out there when we aggregate data across individuals over time. But I think what's promising here is that we do see some strong within person relationships, right? Particularly in social behavior, right? So calling and texting, when that decreases within person, we do see kind of within person decrease or increases in symptoms. And those are the types of associations, which I think is what you're pointing out that ultimately I think we need to focus on.
I can chime in with the question. So one takeaway that I'm getting from your talk, and feel free to correct me if I'm wrong, is that we shouldn't, in these types of EMA studies, measuring social anxiety as like a single item construct is probably not a good idea because, you know, there's different associations with different aspects of it. So I'm curious how you think about, you know, wanting to capture these constructs such as social anxiety in like a comprehensive way, you know, maybe capturing different facets of it, but also balancing not wanting to overburden participants with tons of questions so that nobody actually answers the surveys. Yeah, curious how you think about that problem.
Yeah, I think that's a fantastic question, Noah. I do think that, like, just intuitively, if you think about even like, let's take depression too, right? The items that go into the PHQ-9 are reflecting really different things. Some of them are behavioral, some of them are cognitive. Like, my hypothesis is that we're going to be much better at predicting some of these very behavioral things with passively sensed phone data than we are something like guilt or shame. And I think the same applies, with social anxiety, thinking about maybe more behavioral avoidance versus something that is much more of an internal experience. So, I don't have a great answer of like, how do we balance the need to keep measures short and still get at this heterogeneity? But I think if we, what we're seeing is if we are including measures that have heterogeneous kind of constructs that they're capturing, that it seems helpful for us, or we're better able to predict when we look at subscales, when we look at kind of things that hang together and that reflect really kind of different day-to-day experiences.
Great. Yeah, thank you so much. So we'll transition next to Abhishek Agarwal from the Department of Health Promotion, Education, and Behavior within the University of South Carolina's Arnold School of Public Health. So you can go ahead and start your presentation.
Thank you. So my today's talk is about the independent and the moderating associations of self-regulation and mindfulness on affect and cognition, an ecological momentary assessment study. So we all understand that college students face multifaceted stressors, which lead to different forms of physical and mental health issues amongst them. But at the same time, mindfulness and self-regulation are two potential mechanisms through which they can effectively deal with the stressors and the mental health issues they face. However, most of the existing studies, as my previous speakers have also talked about, have focused on the between-person associations or the global averages of mindfulness and self-regulation while predicting their associations with mental and cognitive outcomes. Therefore, our study wants to focus on the within-person associations of mindfulness and self-regulation with these outcomes. Secondly, most of the existing studies have tested mindfulness and self-regulation as in separate models, whereas we want to club them into the same model and see whether these have independent associations with the mental health outcomes or not, once we have accounted them for each other in the same analytical model. And third is that we want to also test these effects of mindfulness and self-regulation on the momentary perceived cognition, because only a few studies have tested the effect of sleep on the subsequent days perceived cognition, but we want to see the effects of mindfulness and self-regulation on perceived cognition. So the research questions are whether mindfulness and self-regulation at the momentary level are independently associated with our outcomes. Secondly, when we account for the within-person associations of mindfulness and self-regulation with our outcomes, do the between-person associations still remain significant or do they become insignificant? And third, whether momentary self-regulation or within-person self-regulation moderates the effect of momentary mindfulness on emotional and cognitive outcomes. This is kind of our conceptual model, where we are looking at all the variables at level 1, which is the within-person level. So we had 131 undergraduate students with 3,338 EMS surveys collected from them from our university. And this is how the data collection went. We prompted the students 6 times within a day at these time slots, and the surveys went at random time within a specific time slot. So this is basically the semi-random approach of prompting the students, so that we have a much more unbiased and representative sample of throughout the day from all the students. And we collected the data via the XP-Well app. This is how the interface looks like. And the data was collected in the fall 2021 and spring 2022 semester. These are some of the items that we asked the students. Our survey had around 15 to 20 items, each survey, which was asked 6 times within a day. So we conducted, again, the multi-level models. There were 3 separate multi-level models that were implemented using the R software with the NLME package. And we had the interaction effect for the self-regulation and the mindfulness in order to test the moderation. Also, most importantly, we accounted for the random intercepts and the random slopes so that we can differentiate between participants on their at the intercept level and also at the on their effect levels for these predictors. This is the basic demographic information where we had 131 participants, and these are our results. So we found that the within person associations of mindfulness and self-regulation, as you can see, were significantly predicted the perceived cognition, whereas the between person associations as well significantly predicted perceived cognition. And also self-regulation moderated the associations between mindfulness and perceived cognition. But the main takeaway was that after accounting for the between person effects, we still had the within person effects as significant, which calls for the need of conducting more real-time data connection, using more real-time data collection techniques. So this is our interaction model. Secondly, for positive affect, we again found that within person mindfulness and within person self-regulation were significant predictors. But as you can see, between person mindfulness and between person self-regulation became insignificant, which again testifies the fact that we need to deploy more real-time data collection techniques in order to test the constructs such as mindfulness and self-regulation that change at a momentary level. But the moderation effect over here was insignificant. And in our third model, we again had the within person mindfulness and within person self-regulation as significant predictors of momentary negative affect, as well as having the interaction effect as almost like marginally significant. But the between person mindfulness was again insignificant over here. So our main takeaways were that there are distinct and independent associations of momentary mindfulness and momentary self-regulation on our outcomes. And we need to test more at the momentary level than at the usual level because our predictors had a lot of within person variability. And the interaction effect was significant on perceived cognition and negative affect. For future studies, we want to just check upon our response rate and also test the lag effect and the lead effect in order to get closer to defining the causality of the predictors on our outcomes. Thank you.
Great, thank you so much. Yeah, we'll open it for questions now. I could get started with maybe a very nitty-gritty question, but one thing that in my lab we've talked kind of a lot about with regard to these types of EMA studies is when we're doing single item measures of constructs, for example, affect, negative affect to positive affect, we have a lot of debates over should this question be from kind of like negative of the construct, like to positive of the construct, such as like, do you feel very negatively to do you feel very positively, versus do we ask it, as two separate questions where each one is like none of the construct to all of the contract. So I feel neutral to positive, and then I feel neutral to negative as two separate questions. And we talk about a lot about that with, measuring, state anxiety. Like, do we ask, how do you feel from a scale of very calm to very anxious, or how do you feel on a scale from not at all anxious to very anxious? So yeah, my very specific question is, have you thought at all about that type of question, about how you frame these questions? And if so, how do you think about that?
Yeah, I think that's an excellent point, because we also had one item in our survey which was about how you're feeling right now. So which had the entire scale in it from the negative to the positive. But we also had these separate items which we clubbed together as positive affect and negative affect. I think one interesting thing, one interesting idea which you have given me is that I can also explore the potential effects of momentary mindfulness and self-regulation on that particular item. The only limitation is that it's a single item. So, and over here we had 3 or 4 items clubbed together in these 2 variables. But yeah, that's a pretty interesting idea which can be tested. Thank you.
Yeah, I think we have time for maybe one more question.
Yeah, I just want to chime in here. Thank you for your presentation. I actually just want to ask something a little more broad. Where do you feel you'd really like to take this next? Like, what do you see this being the repercussions of for your own research, but also given these findings, all the meditation apps that are out there?
Yeah, so I think one biggest takeaway from this for me was that we need to have a real-time data collection mechanism within our interventions, which should be embedded. And as we delve deeper or further into the analytical procedures, we can deploy much more advanced techniques using the AI models. And also we talked about the network modeling today, which can be then perhaps used for real-time data collection and real-time data analysis, so that we can offer a much more personalized form of recommendation to the participants or to the users, especially since we have the capacities of having random effects for different participants. So we can have a much more individualized approach of recommending interventions to the participants if we deploy more of ecological momentary assessments with advanced analytical techniques.
Great, thank you so much. And last but not least, we have Dr. Evan Golding from Northwestern University. So you can go ahead and share your screen and get started.
Sounds good. Is that gonna work? Yes. All right. So I'm gonna talk about work my group has been doing on a smartphone-based self-management intervention for individuals with bipolar disorder. Not so much focused on the real-time monitoring, but we did do that as well as the passive sensing. I don't have anything to disclose with regard to the talk today. This intervention was really developed to address the need to kind of use smartphones to increase access to self-management techniques from empirically supported adjunctive psychotherapies from bipolar disorder. These therapies typically are aiming at people who are between episodes, and the primary outcome is usually decreasing relapse. And that was true in our study. And then from the literature, there's common targets that are thought to be important. So we propose that these are going to change to impact these outcomes. So taking medications, getting adequate sleep, regularizing routine, and managing signs and symptoms, in particular, early warning signs. And then from the health psychology literature, we would propose that there's motivational, volitional, and environmental determinants that will impact these targets that are hopefully impacting the outcomes. In terms of the intervention, it's a smartphone application with a secure server and website to facilitate communication between human support from a coach and the providers. The app really consists of a set of lessons that provide general information about bipolar disorder and self-management, and then self-assessments and skills lessons. People work with the coach over 4 weeks and an initial visit to develop a personalized wellness plan. And then the core of this application is really a daily check-in where people monitor their medication adherence. Did you take all, some, or none of your psychiatric medications, bedtime, rise time, sleep duration, and wellness on a 9-point scale. And then an expert system, the daily review, provides adaptive feedback based on this data and directs people to parts of the application that might be useful to them, or sometimes directs them to work more closely with their providers. The coach supports, kind of technical and use adherence, but also acts as a concierge to kind of direct people to parts of the application that might be most relevant, getting feedback from the expert system on this. And then they also act to facilitate clinical care communication with the provider and the user. It's a 48-week study. Really, the active intervention is in the first 16 weeks. It's important to note that we stratified at baseline when we did the randomization into what we call low and high relapse risk groups. So the low risk group, which is about 45%, are in what's called asymptomatic recovery. So they're at least 8 weeks out from an episode and they have no moderate symptoms. And then you can see that the high risk group, no one is in an episode, but most of them are recovering. So they're within 8 weeks of an episode. So overall, there was not a statistically significant reduction in relapse risk observed in this study. So the hazard ratio was 0.65, and that corresponds to estimated relapse rates at 48 weeks of 43 and 30%. However, when we look at the strata, we see a heterogeneous treatment effect. So the low risk group strata has a decreased relapse risk. So 0.33 for the hazard ratio, and the estimated relapse rates were 37 for the control and 12%. So I would say this is probably both statistically significant and clinically meaningful. In terms of the targets, medication adherence improved a little bit, and routine regularity didn't change. But I have to note that this population is pretty distinct. So they came in with about a 90 to 95% medication adherence, as opposed to about 60% of people with bipolar generally being adherent. And their routine regularity was 4.8 on a 7 scale that goes from 0 to 7. And most people in the general population are 3.5. And that includes people with bipolar. So, you know, this is a distinct group of people that came to this study. They're pretty motivated. Sleep duration did increase in the intervention compared to the control arm, and sleep quality and management of symptoms and signs improved. In terms of the determinants, we looked at within the intervention, there's an increase in people's confidence in their planning and their ability to do control processes. So monitoring, evaluation, and adjustment that was statistically significantly different at 48 weeks. So that may contribute to the improvement in the early warning sign management. In terms of how people are engaging with the intervention, you know, time spent with the app and the coach are pretty similar. App use is largely driven by the daily check-in, and then the weekly check-in, which is a PHQ-8 and an Altman self-rating mania scale, and then the daily review, which is the feedback for the expert system. So the bulk of this is really going to be the control processes, monitoring, evaluation, and making adjustments. And then the least used was our toolbox for skills development, which was a little disappointing to us. In terms of the app use, it did decline over time. That's shown here in black. And as I said, largely driven by the daily check-in, but people are also using the daily review and the weekly check-in over time. In terms of the coaching, to give you some sense of self-monitoring in real time, we have 24-hour response to changes that might indicate suicidality or changes in functional evaluation. 55% of the participants activated this, resulting in 17% of the providers being contacted, largely activated by a new onset depressive episode. We got feedback from the providers. They did not want to use the published cutoff, but the IRB wouldn't let us do that. But generally, people didn't have thoughts of wanting to die or kill themselves when they got the calls. But there were at least, the mode was 2 for, you know, kind of changes in self-care, sociability, impulsivity, and then problems. This is not working. Okay. So then we did an exit questionnaire. People felt like the daily check-in made them more aware. The coach was supportive and motivating. And as I mentioned, they didn't really practice skills routinely. Memorability was a problem. People didn't use the website or the toolbox and wellness plan as much as we would have liked. People felt the daily review and daily check-in were repetitive. And use decreased in part because of time commitments, but people felt they'd mastered the content or were clinically stable. They suggested changing the monitoring by adding personalized notes and targets, things like diet and exercise, substance use, and then increasing engagement with support, making it more interactive. So, you know, in terms of, like, we wanted to increase access to these, but it looks like the coach is pretty important. So trading off self-guided versus guided is going to be difficult. I do think that adaptive personalization of the target monitoring could be really useful, would allow us to kind of address some of the repetitiveness of the check-ins and reviews, and also changing the questions up using kind of adaptive computerized questions for like the PHQ and the Altman. Maybe people can address skills, and then, you know, figuring out when to re-engage people who are stable. And then obviously the high risk group, these are things that we know are probably important that we didn't focus on our application. A lot of people, including our participants, were involved, and I'll take questions.
Yeah, thank you so much. So yeah, we have a few minutes for questions, so feel free to unmute or write a question in the chat. Yeah, I have a question. So this was, this really excellent talk. Yeah, thank you so much. Could you clarify when you were kind of coding like a relapse, was that depressive and potential manic or hypomanic episodes, or just depressive episodes? And if you kind of coded those differently, did you see any kind of differences in preventing depressive versus manic or hypomanic episodes?
So we didn't look at them separately. So we used what's called the clinical monitoring form. So it's straight up DSM-4 criteria and longitudinal follow back. So everything gets coded in terms of all those kind of clinical statuses. That's for future work and kind of looking at the sensor data and self-report data to kind of compare it. But we didn't look at them separately. There's just not enough episodes. I think there's probably like, as far as to relapse, there's about 49 depressive episodes and about 9 manic episodes. So there's just not enough data to look at mania separately. And maybe 2 hypomanic episodes and 1 mixed episode, something like that. I mean, I would say one thing about this is in terms of personalized kind of treatment, both the group that came to us and the heterogeneous treatment effect and the likelihood that there's even more kind of divisions of the populations, even in this kind of select group of people, is probably pretty relevant. We don't quite know how to dice that up.
Then we have time for maybe one more question. Christine, you can go ahead.
Yeah, thank you. Thank you for the very interesting talk. I'm curious about the regulations in the United States. I'm from Germany, actually. As I understood that the app was personalized and gave personalized feedback to patients. So this would fall under like medical regulation devices in Germany, which really makes it difficult for us at the moment to do studies. What is the situation for you?
No one asked, and we didn't really seek out any kind of FDA approval. No, it is personalized, but it's what's called an expert system. So it's a strict rules-based system. So if you push +4, you're going to get a 1-page feedback that says call the ER, go to the emergency room, call your psychiatrist, and then it hierarchically works down from more severe, like I'd say 70-80% of the content is to do with symptom management. But the real goal is mostly around staying well and learning to manage targets and skills. But it passes through that. So we didn't have to deal with regulatory stuff and exactly who gets what and how that works. We haven't had a chance to look at, and there's probably not enough data. I think you'd need thousands of people. The safety side really came in like our institutional review board and having a 24/7, 24-hour response to clinical deterioration indications. And that had nothing to do with the feedback. That had to do with the monitoring. So even without the feedback, that's a big concern for these studies. And there's a layer between us and the providers. And also this was all comers. So like you didn't have to enroll a provider. We tried, we got about 30% of the providers, 60-some% of the people wanted a provider enrolled, but of the 105 we asked to enroll, we only got 30%. But we would call them regardless if there's clinical deterioration, and you have to have a psychiatrist to be in this study. Or a psychiatric nurse practitioner.
Okay, thank you.
Sure.
All right, thank you, Dr. Golding. And yeah, thank you so much to all the speakers today and everyone who came in the audience. So I think, yeah, that's time. So thank you all for joining, and maybe see some of you at other talks throughout the day. Thank you so much.
Facilitating.
Yeah, thank you.